There we go. Okay. The risk of coronary artery bypass graft, it's not a benign procedure. In fact, when you look at some of the numbers, overall risk for a stroke following a CABG is 1 to 3.5%. Some of the other literature talks about 4.5% in some of the numbers. Other things to be worried about for CABG is the mural thrombi in left ventricle, atheromatous lesions in the ascending aorta, air embolism, and as well as a history of previous stroke, as shown here on a patient following a CABG. So overall, 2 to 5% perioperative neurological deficits, depending on the literature that you're reading. The calculated stroke rate for an asymptomatic patient with a severe unilateral carotid stenosis is 3%. It increases to 5.2 to 11% if bilateral disease and contralateral occlusion are present, respectively. So, like you say, it's one of those things that's 3%, but when you start to add up some of the other factors, such as contralateral disease, again, it could increase up as high as 5 to 11%. And the next, the symptomatic patients associated with an 8.2% incidence of stroke. So it's, then you're starting to get some interesting numbers, and that's why this subject has been brought up. So the risk of CABG and stroke, the risk was in one of the series by Naylor et al. Looked at it was 2%, remained unchanged during their long period of study. 2/3 occurred after day 1. 23% of the patients died, so high mortality and morbidity with this as well. 91% of the screened CABG patients had no significant disease, and less than 2% had perioperative stroke risk. And then the risk increased to 3% in the asymptomatic patient population with unilateral stenosis, 50 to 99%, 5% in those with bilateral, and 7 to 11% with occlusions. So again, one of the things they looked at too, predictive factors for post-CABG strokes included carotid bruit, previous stroke, TIAs, and severe stenosis and or occlusions. So the bottom line for that is CABG, it's not entirely benign. In a pooled analysis in the one study, it was as high as 4.4% in another study by Naylor. So it brings up the learning points for this. It's the need for screening prior for CABG for most of these patients. Again, if they've had a bruit greater than 65, peripheral arterial disease, TIA, smoking, left main, that's about 95% of all our patients getting CABGs. So basically, anybody getting a CABG should be screened effectively. How to screen them? Carotid Doppler is probably easiest and the cheapest. And then we follow up with a carotid CTA if we need to. And then the cases that were questionable, we'll go ahead and do an actual carotid angio. And so what's the incidence of carotid disease in CABG patients? Out of one study of 170 patients using Doppler, 20% of the patients were found to have advanced disease, 6% had critical stenosis, and 3% had complete stenosis. And so, again, the family history of coronary disease, smoking, were all risk factors for the presence of disease. In Hertzler's study, 37% of the patients getting bypass grafts ended up getting an endarterectomy. 9,000 patients in his one study being prepared for CABG, 2.8% had symptomatic or high-grade carotid stenoses, and coronary disease was the cause of death in 24% of his patients that had CEA, looking at it from the back end. And so it goes again, the patients that have coronary disease have a high predominance of carotid disease as well too. And here's the patient as well too. What are the options when you have somebody like this that has bad coronary disease and has a carotid artery looking like this? The different options to think about, well, we're going to talk in a second, but you have to look at it in terms of the significance of the carotid stenosis. Are they candidates for carotid revascularization, either endarterectomy or stenting? And the timing and the sequence is interesting, primarily the symptom status of the patient. Are they symptomatic or are they asymptomatic? The severity of the disease and the urgency of the revascularization. And some of the options that you're going to be hearing about in the next half an hour, or whether you should perform an isolated coronary bypass graft and the CABG alone. This is reasonable in those patients that are asymptomatic carotid stenosis, have a critical left main disease, refractory acute coronary syndromes, or other indications for an urgent CABG. The other option is a synchronous carotid endarterectomy plus a CABG, and that you can do the either with bypass or off bypass for it. And this is a case that we had actually about 2 years ago. You can see just a horrible, ugly-looking carotid stenosis, and this is a totally separate area. With the CT, we're starting to look at, are these high risks? Are these too high risk for a carotid stent? And when I looked at this one, you can see the calcium with the soft tissue core. Looks like a piece of candy almost, like a little igloo or something. We were happy to send this one off for a combined procedure because I thought it was going to be just a little too high of a risk. And so that was one of our patients that we sent for a combined type of procedure. You'll be hearing next about as well staged CEA and CABGs, and then a reverse stage of a CABG and a CEA, and then carotid angioplasty with stenting, followed by CABG, which I'm here to talk about. So those are the different options. And so the management of a patient undergoing CABG who are found to have coexistent carotid artery disease, it remains kind of controversial. For prophylactic intervention is indicated in patients that have had a stroke or TIA, debate still continues. What do you do about asymptomatic bilateral carotid disease? Or, like I said, the next question is it warranted to treat some of these patients that are asymptomatic to begin with? And so we'll talk a little bit about that later if we can. So the combined procedures of doing a stenting with CABG, we'll think about primarily if they've got severe coronary disease, unstable angina, left main, and an actively symptomatic stenosis. But what about asymptomatic carotid patients? Are all asymptomatic patients truly asymptomatic? For instance, when we're looking at with CTA, if the circle of Willis is impaired and there's no communication between the left and the right brains, are they really asymptomatic? If you got high or moderate contralateral disease, likewise Peters cavernous segment with severe atherosclerotic disease, vertebral basilar disease. So we're finding patients, even though they're called asymptomatic, really aren't. And our data is pretty close to what Rod Raby came up with a couple years ago, that when you do a carotid stent, quote unquote, on an asymptomatic patient, they get better. And it's interesting. Here's this is a 77-year-old lady. She used to paint. After the carotid stent, the family noticed that she started to paint again. And the brain is like a muscle. If you get more flow to the muscle, you get better function from it. So I really think it's a question of what patients really are symptomatic and asymptomatic. So carotid stent, then CABG. Here's another CTA of a patient with RCA occlusion. You can see the stent's occluded. Also, there was left main disease in this patient too, so this patient was going for a CABG. But the question is, would you do a coronary artery, or would you do a carotid stent? And then the question is, do you do it right away in terms of putting the stent in, sending them within 48 hours for a CABG, or do you wait several weeks later afterwards? And the advantages of doing a stent before CABG compared to the combined surgical approaches that you're going to hear about later, one thing that's nice is you're able to determine the neurological outcome right away rather than emerging after the patient comes out of anesthesia and figuring out whether you've got an event or not. The other thing is the additional advantages of the staged stenting and CABG approaches. It reduces the risk of AMI during the CEA or in the time elapsing between the two procedures because the interval between them is virtually eliminated. In fact, the MI, the myocardial infarction rate of the time elapsed between the procedure was 4.4% when a CEA and a CABG was performed versus 5.8% with the CABG and the coronary artery stent. And so that's kind of confusing the number, but basically you're able to reduce that MI, in fact, the myocardial infarction rate. And that was shown primarily by the Sapphire study. They got a lot of heat for some of the investigators and all, but basically the premise was good. Carotid stenting reduces the amount of myocardial infarction that you incur with surgery, with endarterectomy, and that fact remains.